Hi everyone. I'm here in conversation with Dr. Bon-Kwon Koo. He's a professor of cardiology at the Seoul National University, and he's a world leader in the field of coronary physiology. Welcome to Dr. Koo to India Live 2024. So, Dr. Koo, I'd like to start with the lecture which you gave today in the conference about post-PCI physiology. We all know that physiology has become the cornerstone for deciding when to do the PCI. But what is your take on post-PCI physiology? Where do we stand today, and how important it is in our clinical practice?
Yeah, I think that's a very relevant question because that the physiology was initially developed to define the ischemia causing stenosis. And for us, it's kind of a yes or no sign for doing PCI or doing a medical treatment. But as the concept of physiology is being evolved to a post-physiologic PCI assessment, because I think it's very important. For example, in the ischemia trial, where they randomized the patient with the moderate to severe ischemia into the PCI or revascularization versus medical treatment strategy, they didn't regard the optimal PCI or degree of the revascularization success to define the optimal revascularization. When operator did the PCI, they regard all the PCI procedures as optimal PCI. Right. And I think that's one of the reasons why PCI could not show the benefit over the medical treatment. Right. And having said that, some may raise the question that we can do imaging, intravascular imaging, and we can do angio assessment so that we may don't need a kind of a post-PCI physiological assessment. It's too much. But when we analyze the data of more than 4,000 patients, around 5,000 vessels, we found that almost 30% of the PCI vessels in terms of physiology, it wasn't optimal. And even 1 out of 10 and 11% of the patients had a residual ischemia. I think this is a serious problem because we are happy to do a PCI every day, using lots of resources. But if that procedure is ending with the residual ischemia, I think our role is not as much as we anticipate. So that's why fundamentally post-PCI physiology assessment is necessary, maybe not to all patients, but to kind of, especially the patient who underwent a kind of complicated procedure, complex procedures.
So in your routine practice, when you do a post-PCI physiology and you find it suboptimal, what is your workflow for correcting it or treating it? How do you go about it?
Yeah, that's another very important and practical question. So that is there anything we can do for the low post-PCI FFR or non-hyperpressure patients? So that if we review the data first in the FFR target FFR trial, when they assessed post-PCI physiology all patients, and they found that in almost 30%, exactly 31%, they found that the patient needed additional procedures after so-called angiographically successful PCI. So in my routine practice, after PCI, so I generally became quite humble when I measure the FFR, because we generally expect the 0.9599, but in the LAD, it will never reaching 0.9899. So it's 0.8 something or sometimes 0.78. So the question is how we can deal with those low post-PCI FFR cases. Mm-hmm. And I am a physiology biased person, so that I try to solve this issue with the physiology first. So what I do in daily practice is that do a FFR pullback tracing or the non-hyperpressure ratio pullback tracing. And if there's a very diffuse disease which makes the FFR gets low, actually practically medical treatment. But at least what is important to us, to the patient, is that we can set the goal of the intensity of our medical treatment. So if in general principle, if the goal is LDL 70, I think if the post-PCI FFR is very low, and if there's nothing we can do mechanically, we have to intensify our medical treatment. The second scenario is that if there's a focal step up, so that it can be an angiographically hidden disease or the angiographically hidden in adequate stent implantation. In that case, I prefer to use the intravascular imaging to define what's the mechanism of that focal step up and to see whether that lesion can be treatable with revascularization or not. And also, I can expect that the post-PCI FFR should get higher after the PCI. So that's my routine practice using post-PCI physiology when the post-PCI FFR is lower than anticipated.
Right. So that was very important points, because once we get the value, we should know what to do with it.
Sure.
Another thing I wanted to ask you is, do you have any specific predefined criteria in which patients you will be doing a post-PCI physiology assessment?
Yeah, so I think that's also a very interesting question. So that the 0.8,
right.
The question is, do we have a specific goal or target? I have to say not yet, but it's around 0.9 or 0.85. It's in between 0.85 to 0.9, I would say. And the right coronary artery, the best cutoff is much higher than left coronary system. But one thing for sure is that the 0.8 is a very straightforward and very important cutoff, because that the 0.8 or residual ischemia is associated with the increase of the risk with the death or MI, such a hard endpoint. So that the higher the better.
Right.
But I have to say that we don't have very strong, solid cutoff for post-PCI FFR like the 0.8 in pre-PCI FFR, but it is very important not leave ischemia after PCI.
Right. So what do you think the post-PCI, where does post-PCI physiology stand right now, and where do we go from here? Do you think we have enough data right now to put that down in the guidelines?
I think the data is enough, but for including in the guideline, we need a kind of randomized trial.
Right.
But there's only a rather small randomized trials failed to prove the clinical efficacy of this treatment strategy, but only for the physiologic efficacy. So we need more data. But I think it's very important to understand that there are more things for us to do, even after so-called angiographically successful PCI.
Yes.
So imaging matters, intravascular imaging matters, and physiology also matters, because we know that to give a maximum benefit while using lots of resources, I think we should try the best, either by physiology and imaging, and I would say angiography may not be enough.
Correct. Thank you, Dr. Koo, for all those pearls of wisdom around post-PCI physiology and navigating us through the not very clear waters right now. Thank you so much.
Thanks for the invitation. Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.